Welcome to On Becoming a Healer. One of the things that has frustrated me is the disconnect between the way in which residents I work with approach patients with chronic pain and what I think we've been learning in recent years about the nature of chronic pain and how it should be managed. It's not surprising that when a patient comes in, for instance, to the clinic where I work with chronic back pain, that there's a sense of frustration. What are we going to do now? This patient has been coming back with this over and over again. They are already taking NSAIDs. They said they went to PT. It didn't help. And what I find is that residents nibble around the edges. They're like, well, maybe we can try a lidocaine patch, or maybe we can refer them back to PT again. There's just a complete disconnect between that general approach to pain as a somatic phenomenon that is stimulated by nociceptive input and the discussions that pain experts have been having that are research-driven. And I've come to see this as a microcosm for all that's wrong with healthcare. There's this efficient task completion approach that we've talked about on prior episodes to tackling every problem. And while that kind of works for some things, like somebody coming in with pneumonia, for instance, it just completely falls apart when you're talking about something as complex as chronic pain. And I have the good fortune of having a co-host, Stefan Kertesz, who happens to have made this his life's work. Stefan, as many of you know, has been an important voice in the dialogue around the opioid crisis, and he's had a particular interest in patients who have been adversely affected by forced tapers. In fact, as far as I know, he's the only person doing a study on suicide as a consequence, potentially, of the forced tapering of patients on opioids. So as I do from time to time, I want to turn the microphone on my co-host, on Stefan. One of the things, Stefan, that I've heard you say is, quote, I still think that the policy world is, quote, addicted to opioids. You've also said the dialogue still seems frozen around what we are saying about opioids and not what we are saying about the care of patients. And then finally, you've said authorities who could influence pain care for the better remain obsessed with opioids and telling us what not to order, but not what to do, or not how to actually approach the care of these patients who are suffering. So first of all, Stefan, I want to welcome you onto your own show.
Yeah, thanks a lot, Saul. It's good to be here.
Yeah, so what I'd like to do is actually start with a broad question, which is why do you think our national dialogue around chronic pain remains so frozen on opioids instead of focusing on the actual patients who we are here to care for?
What I say is that a great deal of energy has gone into teaching about not prescribing opioids in medical schools and residencies. And usually op-eds about pain care usually turn out to be op-eds about why we should not use opioids. So at every turn, instead of discussing, gosh, who are we trying to care for? We're discussing what should we not use and why should we not use it? And gee, how dangerous it is that we used it. And I feel like that's a very narrow kind of discussion. It's been frustrating to me for years. And so that's how I wound up saying currently the healthcare system is addicted to opioids, but specifically addicted to discussing the not use of opioids.
And you can see intuitively why we might have gotten into this rut, at least if you look back to that crisis period where we had this horrific revelation that people were dying in droves because of a process that may have started within the healthcare delivery system, where we were attempting to basically score everybody's pain from 1 to 10. And there was this mandate, pain is the fifth vital sign, and opioids were being prescribed like water. And then the pharmaceutical industry was telling us that's a good thing. It's not going to hurt anybody. And then there's the narrative, of course, is that then sparked this opioid crisis. And so it's understandable that there would have been this focus on trying to just reverse the trend by getting us off this path of putting people on opioids. So can you talk a little bit about that narrative and where we are now?
Yes, it's true that there was a massive rise in opioid prescribing from the mid-1990s to a peak in 2012. It is also true that physicians were not routinely hearing messages of caution or about the risks of those medications. And so I think the message environment was very biased. At the same time, as much as doctors did prescribe opioids, I don't think that they prescribed them like water. I mean, the prescribing went up, but it's not like most people who walked into a doctor's office for anything were handed an opioid. I also think that plenty of doctors felt somewhat wary of what they were prescribing. And, by 2006 or so, OxyContin made the news as a big risk, and the prescribing of that went down. And what was an environment that may well have contributed to ease of initiating opioids as part of an addictive process, particularly for people who got diverted pills, That's not the only reason that the people developed addiction. And it's not like every person who received opioids for pain suddenly became a person with addiction, which is the way the story is told if you watch TV shows and such. But I do agree with that. That was part of what I think contributed to ultimately a market that shifted toward heroin and toward fentanyl. I've talked to patients who say, yep, I got a whole bunch of these pills as a young person from a doctor, and I was off to the races. Although very often that same young person previously was misusing cannabis and alcohol before they got those pills. Like they were already sort of on a path. But I've certainly seen those incidences, and I don't think we should discount it at all. But the more we play it up as that's the whole reason we're here now, the harder it is to add some complexity and nuance, which I think is what has been missing.
There are two questions that I want to ask, and I'm not even sure in what order. The first is to ask you a little bit about how we should be thinking about opioid usage today as, say, generalists or primary care physicians, given that you're concerned that there's so much of an emphasis on just getting people off opioids still, and that we know that's causing harm and that you're doing a major national study on that. And then secondly, how do we begin to have a conversation about actually caring for people who are suffering with chronic pain rather than just talking about a particular pill or class of pill?
Yeah. So one thing you said was, how do we think about opioids in care? And then how should we have that conversation about care of patients? Our healthcare system, to some degree, did get addicted to providing opioids to a very high degree in the late 90s and early 2000s. Not to everybody, but more than was wise. And that was in part because doctors seemed to be in search of doing whatever is simple and easy and right in front of them and doesn't require a lot of depth of understanding. And that mental framework of, I want it to be simple. I don't want to have to think too deeply. I don't really want to have to deal with the messy life of the human being in front of me, was allowed to remain constant and unchanged and unchallenged when we reduced opioids. The idea was, okay, you're going to prescribe all these things, but you know what you're going to do? You can stop. Just taper them down. But again, like the mindset was, okay, we're going to simplify this for you. Just get rid of those pills and you're being a good doctor now by not prescribing or tapering. As long as you do that, you're doing the right thing, which is actually also a simple solution. Like it's still the wrong thing. So the dual challenge, and it's really a problem, is on the one hand, I think there's an argument to be made to discuss opioids as relevant and useful in care. And at the same time, I am pretty worried that we still aren't talking about actual patients as human beings who have complex drivers for their pain, which are not easily resolved by any single intervention and certainly not easily resolved by opioids. So which part should I tackle first?
Well, first, I just want to highlight something you said, because I think it is so interesting and so important, which is that the same mindset that led us to mindlessly prescribe these pills in increasingly higher doses because it was a simple task, a simple intervention that was not well suited to a complex problem, is the same mindset that's allowing us to just dial it down and create chaos and pain and suffering in another way. And neither of those approaches actually gets to the fundamental question of how do we work with people who are suffering from chronic pain. And I think that's really the interesting thing. Now, one thing that I'm curious about is I feel like there is a large body of knowledge now about what chronic pain is, what's happening in the brain, what its connection to the biopsychosocial model, and what better approaches are. I talked about earlier how there's a huge gap, a chasm between what's known and what's typically done. I'm curious, back in the 1990s and 2000s, did we actually have the body of knowledge we have now about how to manage chronic pain and we're ignoring it then? Or is our understanding, even if we're not really taking advantage of it for the most part, or at least adequately, something that's just evolved in the last 20 years?
Okay. For at least 50 years, there have been pain experts who've considered pain a profoundly psychological experience that involves behavioral responses to perception of threat, that there are schools that worked on this, particularly in the Pacific Northwest, and that there's some depth of understanding dating back decades that was looking at pain holistically and in terms of the human mental response to the perception that one is under great duress, which is often driven by, a mixture of factors. So I don't think that there's entirely new knowledge. However, it's also fair to say that the last, 20 years or so have seen a burst of research focused variously on trying to help people cope with pain, either by reprocessing what it means to them. That's called pain reprocessing therapy, other therapies, which in some way are trying to build on that. So we have more knowledge now than we did, but I'm also aware there were historic scholars dating back 50 years on this.
Yeah, I have to say that that paper on pain reprocessing therapy, it was a randomized controlled trial in JAMA Psychiatry in 2022, really did uh, impress me. It was a randomized controlled trial in which the intervention was a form of cognitive behavioral therapy that ran for about 8 weeks, that was customized to the current understanding of how uh, chronic pain is connected deeply to a kind of a fear model. The idea that when we're experiencing chronic pain, our brain is essentially in a sort of dysfunctional cycle of perceiving essentially a dangerous situation that in turn heightens the pain, which in turn heightens the fear, and that cycle has to be interrupted. It's not intended to be a perfect model. It's intended to be just a component of understanding
Yeah.
what contributes to chronic pain, but a big component that's grounded in a lot of research. And the CBT that they developed around that was really impressive against a control group in terms of not only reducing people's pain, but at 1 year follow-up, the pain reductions, the impressive pain reductions persisted. And they weren't implying that this was the only approach to pain, but that this approach is remarkably effective at reducing pain. It obviously doesn't involve any pills, but it does involve a relationship with the patient and an understanding of the complexity of how to work with people who are suffering. Yet, despite that study and others like it, we're still stuck in this rut where we're just talking about dosages. So, given that on the one hand are these studies like the one I just mentioned and the persistent, rather simple-minded approach that you described, what are your thoughts at this point about where we are in terms of our understanding of chronic pain and how it's meant or not, and how that knowledge is being used or not used in clinical care?
So, like you, I'm very aware that clinical care is narrow, it's bereft, it's a sequence of I'll refer you to this, I'll refer you to that. There's not a lot of depth of thought about what's going on. The way I actually encourage others to, and I try to think about patients with long term severe pain myself, and we're talking long term here, not somebody who's just had surgery, is I kind of think about the potential things that could contribute to the sense that one is suffering. Those can include biological and tissue injuries, which may be recurrent. They don't necessarily stop. They include mental health conditions that one already has, particularly post-traumatic stress disorder, because if you've been traumatized, you're going to be acutely sensitive to the new possibility of trauma. Whether you have social support or you lack it, which is one of the things that can buffer you. I think about, does the person in front of me have a current or a previous substance use disorder? Are there medications that might have dependence effects and might interact with their experience of suffering every day? Those might be the opioids themselves, but they could be any other medication. I then consider their level of ability or disability. What do they need to get done each day? And what is it hard to get done each day? I ask myself about health system trauma and distrust, because whatever I'm going to do, particularly for somebody who already has disability and long-term pain, and whatever I'm going to propose is going to be run through a filter on the patient's end. And they're going to say, can I really believe you? Can I really believe that you're there for me? So health system trauma, which we really cause a lot of, and distrust is part of my evaluation of somebody with long-term severe pain. And then whatever decision we're going to make, the decisions are going to be influenced by what are the other medical concerns this person has at this very moment in time that we also have to address, whether they're having chest pain or they have diabetes the day I see them. How much time do we have to work with? And what already was tried by others before, and did it work or not? I think of these as a cluster of factors that are going to weigh on the decision of how we help them think about their own pain and what we can do. That is my matrix for thinking about this. And I don't see it happen very often in clinic when I'm precepting residents, and I don't see it in notes when I read notes written by other doctors. I see them writing, what you said, back pain, already had MRI, tried lidocaine patch, add gabapentin.
Yeah.
It's really hollow. It's like, wait, all the things that you should think about are missing there.
When you were just giving me a concise overview of your approach, I think what you didn't say, and I just want to add it because I think it's there for you, is that this is all done with engagement and caring. And
Yeah.
yeah, I just want to emphasize that I hope that when I walk into a room to see a patient who has chronic pain, and let's suppose it's a patient with chronic back pain, for instance, the most important thing for me is just the connection itself. Is just to
Yes.
sit down and just talk with them a little bit about what they're going through, and to listen.
Yes.
And this is not an act. Again, it sounds corny, but it's a genuine sense of shared humanity. It's a genuine chance to just hear who this person is and what they're going through, to express sympathy, which is real. I feel it. And then to talk a little bit about what they've been through and what they've tried and so forth. And then maybe to begin to talk to them a little bit about what chronic pain is. And I think this is where we get into a sticky area, because the last thing people want to hear is it's, quote, all in your head.
My goodness.
And yet, our understanding of pain, not just chronic pain, of acute pain, is that it is in our head. That is not intended to be a put down. If you stick your finger in a fire and it burns, a signal goes to your brain, and your brain decides that this is a very bad situation and that it needs to do something about it, and it generates a pain signal in your brain. And similarly, if you have chronic pain, the pain experience is generated in your brain. Now, there are different sets of pathways, but in both cases, you're experiencing genuine pain. And so I think in some way, we've done a disservice by sort of telling people over decades that there's sort of real pain and then there's pain in your head.
Oh my
when
God.
in fact,
Yeah.
and that's just gotten so solidified that patients will just be, Doc, what are you telling me? Are you telling me this is all in my head? And so I think this is one of the challenges that we have. And honestly, I think residents, and I don't mean to pick on them, but those are the people I walk into exam rooms with, have to some degree this idea that that there's the pain you get when you break a bone, and then there's this very frustrating situation that's every day where patients come in and they're complaining they're in pain all the time, and there's nothing we can do about it.
They create a dichotomy. They don't.
Exactly.
We teach the dichotomy. It's not that they
Yes.
create it. What you said at the beginning is that this conversation doesn't work unless you actually care about the person in front of you. So it's hard to fake genuinely caring for a person in front of you. But if you are really genuinely interested in their life experience and what they've been through, then the conversation about what is impacting your suffering at this time, whether it's a mixture of physical stuff, social stuff, financial crisis, or distrust of this very building that we're doing the care in, all those things are on the table and are easily on the table if the patient believes you are a trustworthy person who actually is genuinely there for them. And none of those things really work very well if the patient is not convinced that you are on the level.
Absolutely. And I think that in many ways, our approach to managing chronic pain is sort of a litmus test for the kind of physician that we are. Because in a sense, our patients always need us to care about them and to walk into the exam room and be interested in just what's going on with the person in front of us. But we can, to some extent, quote, get away with not doing that for a lot of things, right? If somebody comes in with strep throat, and as long as they walk out with a penicillin prescription, it's probably okay. But the fact that it's causing them to miss work, that's creating stress in their relationship with their spouse, that their boss isn't happy about it, if that's something that comes out during the visit because of the way we present as caring people, that's going to be a better visit for them. And it may actually change the way in which we approach the care plan. But if none of that happens and they walk out with penicillin, at least that's
probably good enough.
Probably pretty good enough. But when somebody comes in with chronic pain, if we're basically efficient task completers, and that's the rut we're stuck in, and it's either opioid dose up or opioid dose down, or, let's try a pain patch or whatever, or refer them to somebody else, it's failure. And I think that's really, unfortunately, where we are, and where talking about it is something that I think is critical, even if it involves maybe pointing some fingers. And one of the areas I want to point at is the American College of Physicians. And it came up in a conversation you and I had before we turned on the audio recorder. It was something that we talked about. They actually put out a position paper last year in Annals of Internal Medicine. And I'd like you to talk a little bit about that position paper. It had to do with
measure care.
Yeah, how to measure performance in the care of patients with chronic pain. And I'd like you to just say a few words about what they decided was important and what they decided was not important.
So, in principle, a performance measure is a way of assessing either the care provided by a doctor or the care provided by a health plan, sometimes even a bigger unit than that. It's the thing you can measure, and where, in theory, if the measure goes in one direction, the entire care plan is doing generally better, or the doctor's doing better. And if it goes in another direction, it's worse. So it's a little bit different from a guideline. But performance measures are very, very incentivizing, because once they exist, entire health plans and doctors change their practice in order to ace the metric as best they can. And they also represent usually consensus of very powerful groups. And what really got my goat last year is that the American College of Physicians issued a set of recommended performance measures for the care of pain. And here are the performance measures that they endorsed. One was the use of imaging for low back pain, specifically at the health plan level. They want to see less imaging. The next was use of opioids at high dose. Specifically, they want to see less use of opioids at high dose. There are a few others that had to do with opioids from multiple prescribers, opioids and benzodiazepines, and all these things. They want to see less of them. And then the one thing that they gave thumbs down on was a measure of patients' experience of receiving desired help for pain. They're like, nope, we're definitely not going to support that. So first of all, even though this is just a performance measure and not a guide for all of care, it still is an articulation of values. And, to have a big red thumbs down, which is what they have in the paper on patients feeling helped, sends a real signal, particularly when everything else is actually an instruction on what not to do rather than how to help a patient.
It's pretty shocking if you think about it. Here is a leading physician organization actually saying we definitely are not interested in whether patients feel that they're having a positive experience in terms of the help they're receiving managing their pain. And then they have one reference. It's reference 17 to justify that. And so I was like, okay, I really need to go find reference 17. And it's a paper that was published in 2017 that has the title, Patient Expectations for Management of Chronic Non-Cancer Pain, a Systematic Review in the journal Health Expectations. So I went looking for it. Is this going to be some study that just says, after, looking at hundreds of papers, we've definitely concluded, do not listen to patients when they tell you that they're not happy with the way you're managing their pain. And that's not the way I interpreted that paper. In fact, what they do is they start by saying there are different definitions of what we mean by patient expectations. And they distinguish in particular between two kinds of expectations. One is what they refer to as ideal expectations, and the other is what they refer to as predicted expectations. Ideal expectations are what a patient will say would be fantastic if their pain could be managed that way. And they basically say they would love to have complete relief of their pain. But they also acknowledge that that's not what they expect. And what they found is that expected expectations, which they also refer to as predicted expectations, are far more modest. And they basically said that when we work with patients, we have to really work with their expected expectations as opposed to their ideal expectations. And in fact, they conclude by saying in clinical practice, it is important that predicted expectations of the patient are known to the treating physician and discussed rather than just ideal expectations. So nowhere in that paper did I see or would I have drawn the conclusion that they're saying that we should not be valuing patients' expectations for the physician's management of their chronic pain. So I'm left wondering why the ACP felt that they needed to put a big red thumbs down on what they call consideration of patients' experience of receiving desired help for pain.
Yeah. I mean, and I think we should want to know what patients' experience of receiving desired help for everything we see them for is. That doesn't mean that it's the Bible. If you're a fundamentalist, it doesn't mean it guides every single thing you do. But I would want to know, if it's okay, I'd like to cycle back to the problem with ACP endorsing a quality metric for health systems that's related to opioids at high dosage. That it turns out to be a posture that is diametrically opposed to the position of the Centers for Disease Control and Prevention at this time. And the storyline is as follows. At one point in time, we recognized that there was a correlation that might even be causal in some instances, that prescribing opioids at high doses as a routine matter was often not paying off in terms of well-being. Not that it never paid off, but it often wasn't. And it usually did involve some level of increased risk. And in the ideal, setting up a plan-level measure that says, hey, we'd like to see the overall number of patients on very high-dose opioids be something you eventually get down over time, seemed like a reasonable proposition. And in 2017, some of the major organizations that guide healthcare did that. Even the Centers for Disease Control and Prevention put in a bright line 90 milligram threshold in their 2016 guideline. But at the time that they did that, many others of us were worried that once you set that expectation, given how poorly physicians engage with patients around this issue and many others, they were going to ace the metric by reducing opioids in all instances without care for individual patients and without understanding what was going on for them. And sure enough, that is exactly what happened. And in fact, there then flowed many, many individual stories of patients who were deeply traumatized and harmed. I heard of patients who were harmed. I saw a patient shortly after he shot himself because his opioids were cut off. And beyond that, there were large studies that showed that there was a correlation that looked like it could be causal in some instances where stopping or reducing doses was followed by significant harms of all kinds to patients, ranging from loss of continuity of care, meaning leaving the healthcare practice, loss of control of medical diseases, sometimes mental health crisis. And I'm not saying every person had these happen. I'm not that naive. Some people wanted the reductions, or they said, you know what helped me? People are diverse, but there was a lot of harm. And eventually, after all of this, the Centers for Disease Control Prevention, its revised guideline of 2012, guidance and statements they issued in the subsequent years is, you know what we should not do? We should not have a quality metric that's based on dose. And in fact, in early 2024, there was a meeting of a big group that advises the government on quality measures for the Medicaid program. And in that meeting, both the author of the CDC's guideline and a few other people, including myself, said, please get rid of this measure of quality. This measure of quality based on high dose has proven detrimental in practice. It has no place in measuring care. And the group that was listening to heard it and voted and said, let's get rid of it.
Yeah, I just want to draw a direct connection between what you've described and the ACP's total disregard for patient experience of receiving desired help for pain. Because if you are a physician who looks at the ACP guidelines and says, okay, so what the patient thinks doesn't matter. I'm not comfortable with the fact that they're on X dosage of an opioid, and I'm just going to cut it back. I'm going to cut it down, even though they're not happy with it, even though they say it's going to, ruin their life. Honestly, that's not what matters. What matters is the performance measure that says that I need to get this number down, and that's actually what I'm being incentivized to do. And I'm also being told the fact that the patient's unhappy is not important. And so that gets you to the catastrophe of a patient who potentially may die by suicide, which I know is something that you've been studying.
Yeah.
And that's obviously the worst possible outcome. But it's also really It's really interesting in a negative way that we're saying that the patient's voice doesn't matter.
Yes.
And where else in healthcare would a major organization say that in this current era? I think there's a basic concept of patient-centered care and an ethos that you work with the patient. You don't do things against the patient's will, and that the patient has a critical voice. And again, I'm talking now specifically about the patient who's been, say, on long-term chronic opioids. And they happen upon a physician who thinks that, their number one job is to adhere to performance measure number.
To adhere to performance measure CMIT 748.
Yep, that's the one. Get that opioid dose down. And so I think this is the mindset. And I think one of the things you said about, again, the ACP position paper is that the patient is essentially invisible. It's all about radiographs and dosages and who's prescribing these, and it's very explicit. Patient is not part of this this conversation.
So that is, absolutely the value system conveyed by the performance metrics. But I'd like to talk about the letter we wrote to the journal of this organization, to which I pay dues, by the way, and I generally am in favor of the ACP. But we wrote a letter to the ACP saying, first posted electronically late last year, saying it's really a problem for a major professional organization to take a posture diametrically opposed to that of the Centers for Disease Control and Prevention. We think the CDC got this one right. They understood that, they had emphasized dose before, but it turned out to be harmful. When they said, let's roll that back, they got it right. The data supports them. And the response eventually was posted electronically, and it's going to be in the paper journal this month. And the response was, we'd like to thank Dr. David Kertesz for his comments. By the way, my name is not David. And as if to emphasize that they really had not read what we wrote, they said, it seems like there's a real difference between a guideline and quality measures. And we're only interested in quality measures. We're not interested in offering a guideline. And so quality measures are never meant to guide the care of individual patients. We're sorry you didn't really understand that. And the truth was, of course, our letter said the problem is the quality measure, and the quality measure was tried in practice and failed. But apparently, from their perspective, David Kertesz didn't get it right. I kind of felt like, being Stefan Kertesz, they hadn't read our letter right. It'll be published this month, but ultimately, they still kind of are hooked on a model of measuring care at the abstract level, even if it harms patients. And in this case, it was found that it harmed patients.
Yeah. So speaking of David, I want to talk about another David. His name is David Shulkin.
Okay. Oh,
And
let's go to David Shulkin.
yeah, so Dr. Shulkin was the Secretary of Veterans Affairs during the first part of the first Trump administration. And before that, he had been the undersecretary during the Obama administration. And just a couple weeks ago, on September 19th, he published an article, an opinion piece in The Hill, which is a major Washington news source, with the title, Whiskey, Tobacco, and Pain Pills, the VA Can Be an Opioid-Free Health System. And then he begins by asserting, and you pointed out to me that this is asserting falsely, that, quote, more than half of veterans receive opioids upon surgical discharge, and roughly 10% of those patients later develop opioid addiction.
Yeah, that's false.
Yeah, you pointed me to a paper that said that that's off by 50-fold. It's actually 2 per thousand. But I want to talk a little bit about what's going on because, as you pointed out to me, especially taking into account the Sunshine Act, which gives you access to information about conflicts of interest, of how this whole virtue signaling around eliminating opioids without really talking about its impact on people has become almost an industry, and in some cases a profit industry. So do you want to talk a little bit about that?
Yeah, and I'll say straight up, we're not here really to discuss the VA. We are both employed by it and are not authorized to represent positions and postures of that organization, and we're not attempting to. What we're trying to look at is what does it mean when somebody with a lot of authority and history publishes an op-ed that says the goal is to make any healthcare system opioid-free, and then alludes to a particular drug that was recently approved by the FDA in service of that objective.
He says the first selective sodium channel blocker for acute pain, which refers specifically to suzetrigine.
So he basically names the mechanisms of action of one drug that was approved by the FDA very early in 2024 for use for postoperative pain or for acute pain, and had succeeded in some randomized controlled trials as being better than, or at least as good as, a 5 milligram hydrocodone in people who had undergone bunion surgery and who people who had undergone tummy tuck surgery. What he doesn't say is then he had received $60,000 but from the organization that sells that particular medication.
From the company, Vertex Manufacturers.
Yeah, and so Vertex. He sets up this giant dream of a system that never prescribes opioids. I don't agree with the dream of that system. I don't think that makes much sense. We've just been talking about the fact, and we're going to get to more of this, I suspect, but the decisions around opioids are complicated. But the idea that an entire healthcare system will get rid of a category of medication based on a new FDA-approved product that has been shown to work in certain postoperative situations is kind of bizarre. But to not disclose that one is being paid to share that message is even more concerning. Neither the publication was aware of this conflict of interest, and it's particularly concerning when a former secretary of a major federal agency who knows all about conflict of interest feels that they don't need to disclose that they're being paid at the same time that they're saying these kinds of things. And yet it's another example of what we talked about before when I said the system is addicted to opioids, and by that I mean stopping them. The conceit of this whole paper is we're going to make the world a better place by getting rid of a chemical. That is really not how we make the world a better place. It's really not how we help individual people.
Yeah, and so what's challenging about this conversation is, on the one hand, of course, opioids have caused
harm,
devastating harm, and at the same time, the obsession with just talking about that class of drugs and how to get rid of it reflects the same problem that got us into this crisis in the first place, which is not thinking about the nature of suffering in people with chronic pain and how one can function as a healer, to borrow a word from our podcast, in helping people cope with the impact of chronic pain on their life. And the fact that there's this persistent erasure of patients in the conversation.
Yeah.
Whether it's the ACP or whether it's a public figure who has run a large healthcare system and who just keeps coming back to this boogeyman. So the question is, where do we go now? And I think there are two issues. One of them is very concrete, which is, where, in your view, do opioids fit into the current management of chronic pain? What should we be telling physicians about opioids and chronic pain? And then the second question, which is a much bigger one, is where do we go from here to really switch the dialogue from talking about these efficient task completer interventions, whether it's slapping on a new pain patch or referring somebody for an injection in the back, to How do we train physicians who can engage with people who are suffering and who can partner with them in ways that get to the deeper challenges of managing chronic pain? But let's start with the first one. Let's start with
Yeah,
this
totally.
opioid issue.
So, first, what I would say is for somebody who has significant long term severe pain and disability, which is a subset, the first element means you have to learn everything that's going on with them up front. And it's this whole wheel of issues that I described at the beginning, from what might be ongoing tissue injury to whether there are social supports or not, to whether they have a disability or not, to whether they even trust you or not, and to what was tried before. You have to learn all those things to make a plausible recommendation. And when I am considering what I am going to offer a patient, it's going to be based heavily on those things. If a person's already on opioids, I'm not going to start with opioids are bad. If a patient has never been on them, I'm not going to start with I'll never prescribe them, by the way. I'm going to start with, gosh, let's consider the full range of things we could do here that have some chance of helping you, whether it's a medication that is not an opioid, whether it is a non-pharmacologic form of help, which might be physical therapy, which, if it's rightly done, can be very helpful, or other physical interventions, or it's a cognitive intervention of some kind that would help someone, or maybe it's a combination of the three. A lot of these things are going to be geared toward helping a person adopt behaviors that they might have given up before, like getting out of the house, going to groups, being involved. But in this discussion, I would highlight that almost any single intervention that's been tested in randomized controlled trials has tended to have modest effects versus placebo, not gigantic effects. And what that means is that they're probably helpful for some and not helpful for all. And that includes opioids. Now, given the downsides and given the limitations of the randomized trial data, particularly for long-term use, they're probably not your first, second, or even third choice. They might be your third or fourth choice as part of a package that you're working on in partnership and negotiating with each person in front of you that relates to what they can actually do and what they can actually deal with. But in terms of evidence of opioids, well, there is a reasonable body of randomized controlled trials that were submitted to the FDA, which suggests they have some helpfulness for pain that is chronic. And yet those trials typically conclude by between 6 weeks and, 20 weeks or so. And then there are long-term follow-ups of patients who have been in those trials, where anywhere from 32 to 42% of those patients seem to have an enduring benefit from their perspective without an increase in dose over time. That doesn't prove that every such patient would have done worse if they had not received opioids long-term, but it does suggest there's a group that may be benefiting over time. The other thing I'll point out is that one of the most commonly cited papers to suggest that opioids are no better than Tylenol, which is typically the way it's misquoted, is from a trial that compared two groups of veterans who consented to be randomized for a 1-year trial. And one arm of the trial received a whole bunch of different therapies that built up over time with low-dose opioids as the final option. And the other arm of the trial received aggressive opioids with dose increases. So in these two arms, they were followed for a year, and roughly the veterans in both arms did about the same and had about 60% improvement 1 year out. Does that mean that aggressive opioids were inherently better than this other approach? Nope. Does it suggest that opioids have absolutely no benefit? No, probably not. At least among these people who randomized to be in the trial and wanted to be randomized, they said their pain was 60% better at a year. There is some contestable evidence that you can say, look, there's probably some benefit for some people, and I would not take that off the table. And certainly when someone is in extreme distress and can't really even participate in any of the activities you would do, whether it's cognitive or behavioral, to help them, you're going to have to reduce that distress just to engage them in care. And sometimes, if pain is a highly distressing experience in your brain and it's distracting you from participating in care, sometimes you have to treat the pain in the brain. And it turns out that opioids do go to the brain.
Yeah, so I think that as a non-addiction specialist, I think there's sort of two messages I get from you. One is that if you inherit a patient who is on chronic opioids, even at relatively high dose, and they're functioning well, and they've been on a stable dose for a long time, don't, with rare exception, taper them against their will.
Yeah, there's rare
That's
exceptions,
the first
but they are rare.
There are rare exceptions. I can imagine a situation where you are very concerned a patient is in danger. Let's suppose they're on remarkably high doses. They're also taking benzodiazepines, and they don't want to go down. There may be a situation like that where you might feel like this is not safe. But I think the point here is, regardless, you're not discounting, you're not putting a red thumbs down on the patient's experience, taking it very seriously in all these cases in your decision making. And in only rare instances would you go against the patient's will in tapering them down. That's the first thing. The second thing is, would you ever start a patient with chronic pain on opioids?
Yes.
And I think what you're saying is it wouldn't be your first, second, or third, or maybe even fourth choice. But
Yes.
what you might do is, in a patient where you have a relationship-centered approach to care, and I won't read the whole case because it's too long, but you did share an example with me recently of a patient who you've been working with for a long time, and you've tried a lot. And again, and this was a good example because this is a patient who had substance abuse issues, who had cocaine issues. So this is the kind of patient who many doctors would be like, I ain't going anywhere near giving this patient opioids. But after a multimodal approach to working with this patient who had a lot of psychological issues as well, you made a decision to put them on a low dose of hydrocodone, and in the context of a relationship, and it turned out to be quite helpful for this patient, right? After everything else had been tried. So I think your point was that you were willing to do that because it was in the context of a complex multimodal approach to pain. And it did actually help the patient considerably because, according to them, right? Which apparently some people don't think is important, but according to them.
According to people who watch the patient, like I see the patient in the office, but I work with a team of people who actually go to patients' houses when they're formerly homeless. They actually go and see how they're doing. And in the case of the team I work with, they actually had to go to where this 74-year-old person was working, helping fix cars, to find him one day. Like, they're like, this is an improvement. The guy is 74. He's pretty significantly disabled. And what he wants to do is do detailing work on cars and help fix cars at that age. He's probably doing okay. Is everything perfect? No, it's not. Do we still worry about the prescriptions we're offering? Yes, we are. But is he doing better? Yeah. So I don't see a role for saying they're never to be started.
Yeah. So I think where I want to kind of perhaps end the conversation is to talk about how we as a profession fail in a way that is more fundamental when it comes to caring for patients with chronic pain because of a problem we have in our whole approach to care, which is the efficient task completer mindset.
Yes.
That there is no place where we do more harm, I think, as efficient task completers, which are, we've become sort of cogs in this machine where we're interacting with a computer, where we're, looking for what order do we place, who do we refer to, et cetera, so we can move on to the next issue or the next patient. There's no part of medical practice where that is more harmful than in patients who are suffering because of chronic pain. And so the solution has to involve thinking about the whole nature of the way in which we train people to practice medicine, and also the environment in which they practice, where there is so much pressure to essentially be a profit driver, to basically do procedures and refer patients on. Now, I will say, for instance, again, you and I both work within the VA system. I also work outside the VA system. That the VA system does, in actually some fundamental way, care about the whole veteran in ways that I often don't see outside the VA system. And there are integrative health opportunities for referring patients. One that I wish we had, I haven't seen pain reprocessing therapy within the VA.
Yeah.
At least, it really, in my view, captures this holistic approach where a caring professional works with the individual to identify the way in which pain is connected to fear and anxiety, and is able to have a long-term benefit on that patient's pain experience and on their function. And I also know professionals in the VA, and there are not nearly enough of them, who have this deep understanding of chronic pain and how to approach it and how to focus on function and how to really work with patients that takes into account our understanding of the chronic pain brain model. But there aren't enough of them. And also many, if not most, primary care physicians are still functioning with this somatic pain model, nociceptive model. And I can definitely say that we're still, for the most part, training residents in that extremely outdated approach.
I think that the simplest thing I do say when I am in a teaching situation is to show people the wheel of considerations that go through my mind. So I might start out a conversation, tell me what's going on for you. Tell me what concerns you have had about your care before and what you're hoping we might accomplish here. But in my mind, I'm ticking through, is there biological or tissue injury? Is there mental health concerns, social support? Are there dependencies on medications or non-prescribed substances? Do they trust the healthcare system, or have we done something that caused distrust? And what steps might I need to repair that distrust? And I'm still listening through, what are the other medical issues we might need to address today, and what has already been tried? I think we can still teach the idea that, look, start with, hey, it's great that you're here. Tell me what's going on for you. And then to have a little bit of a mental model that there's probably a lot of things going on in a person's life that are going to be relevant to making the right choice. And if you're ticking them through and gradually collecting them, even if it takes several visits, in pitching ideas over time, you'll see what works with the patient in terms of what they're open to and what they can do.
Yeah, and the one thing I would add to that, or maybe emphasize, is asking them about function. Asking them how is
Hmm,
how is chronic pain that they're experiencing affecting what they can and can't do, and get very specific about that. And then ask them what is it that they would like to be able to do
I like
that
that.
they're not able to do because of the pain they're experiencing, and then really starting to talk about how you can get them back to doing the things that they want to do that they can't do with their chronic pain, and functioning, perhaps shifting the conversation a little bit more towards function. And I know that there's research to show that when you focus on function rather than on the pain itself, and on encouraging people to do the things that they value despite their fear of the pain, that has this remarkable effect in many cases in actually making the pain experience less severe for them. And so I think those are holistic approaches to working with patients that are just non-aligned with what order do I place, and the general impatience and frustration that is so commonplace now, unfortunately, given the kind of industrial model that we have for the way healthcare is practiced. And I will also say that one could have the impression that the approach that we're advocating for is incredibly time consuming.
Yes, one could.
Yeah, one could. And I don't actually think that that is true. And I don't want to give the impression that you can have your cake and eat it too. These conversations do involve time. But I think that when you walk into a room and you care about the person who is suffering, and you let them know, that you are going to be with them on this journey, and that it's not going to necessarily be solved in the first visit, that it doesn't necessarily mean that this is going to be like a 4-hour visit. In fact, my experience has been is that you can see patients they look visibly relieved when they see that the physician cares about them. Um, that this is not going to be an antagonistic visit, which is what they're so used to. They're so used to being stigmatized, to feeling like that there's going to be immediate suspicion of them, that they have some sort of ulterior motive. That as soon as they realize that that's not what's going to happen, you see this calming effect in men. Not all of them. Some of them have had so much negative experience
Yep.
that you don't get that right away.
Nope.
But I think that it's one of those situations where even if the patient doesn't necessarily respond positively up front, that you can set clear boundaries and say, look, I know that you've had a lot of really bad experiences. I'm certainly going to work with you on this. We're not going to solve this necessarily today, but I'm here and we're going to do this together. And that becomes the beginning of a relationship, and that's the way in which you frame this. I think that is an approach to patient care that we're not teaching, we're not modeling, and that in my experience, many trainees it's just alien to them.
Yeah.
And I think that's really where this conversation needs to start as educators.
I'd like to offer a closing remark, which is to remind myself, but also our listeners, that we've had episodes a few years back on boundaries. And the boundary that I learned about most from you, Saul, is the part of me that can sometimes be very afraid that I haven't pleased someone right in front of me, as if I need them to tell me, hey, everything is good that you just did. And when we talk about saying to a patient, I'm really here for you and I want to be helpful and I care about what you're going through and I want to understand it, and we may not solve it all today. At no point in that story do I demand that the patient make me feel good that I did a great job that day. If they say, currently I think you're full of shit, I don't need the patient to make me feel a certain way for me to be engaged and committed to them. That's a boundary. I will worry about, relationships that make me feel good about myself in a few other domains. But when I'm trying to advance someone's health, I want to be totally engaged. But one of the things that's not the patient's job is to make me feel good about myself.
Oh, that is so important. When I've informally surveyed residents about the patients they quote like and the ones they don't like, the most common thing I hear about the ones they like is that they get positive feedback from that patient.
Sure, we
The
all like
patient,
that. I mean, I like candy
yeah,
too.
but I do think that is very problematic, because when somebody is chronically suffering, they are grumpy, they're unhappy, they've been stigmatized, they have distrust, and to expect them to respond positively all the time when finally a physician cares about them is expecting the impossible. When it happens, it's nice. And I'm just going to repeat what you said because it is so important that it's not the patient's job to make you feel good about your job. I think if you know that you're caring about that person and that you are going to do everything you can to be helpful to them by getting to know them and by working with them, that's all that you need to know about how you're practicing medicine. If the patient is still bitter and sarcastic and negative, that's just part of the package. That's part of what you have to contend with, which in some respects is the negative experiences they've had that have brought them to this moment. So yeah, that's another challenge we have to face in the way in which we train physicians, that they have to get over the idea that it's all about them.
And once I get over it, then I actually am genuinely interested in the patient's experience of receiving desired help for pain, the very thing that they got the big red thumbs down. Then I'm actually really interested. And sometimes the patient will say, I don't feel you helped me today. And I'm still like, okay, that's really important information. We're going to continue to work on it. And I'm not distressed. I'm not threatened. I just like, okay, that's information for us to work on together. Great. So thank you for this chance, Saul. I really enjoyed this.
Yeah, thanks, Stefan. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.